interesting because I'm an academic family medicine, and we are the poorest paid family medicine doctors. And my life is amazing. All my loans are paid off. I'm taking my mom to Greece next year. It's good. So, academic family physician. Basically, we teach our learners to guide our patients through the challenges and choices of life. That's what we do. And it's an honor. It's a sacred honor. I really enjoy it. Pager goes off. Yeah, some of us still use pagers. Don't judge. Pager goes off. Labor and delivery. Let's go deliver a baby. It's July, I should mention, which all attendings are going, It's July. We're going to go deliver a baby. Get up there. I have the world's most gigantic intern. As an attending, one of the most important things you do is you assess your learner, assess their level of learning. It's like, so, how many babies have you delivered? It's like, 2, Dr. Crichlow. Okay, let's get dressed, get the blues on, and now let's just go towards the vagina. It's like 2 hours later, mom is a prime, she's completely exhausted, and that really experienced labor and delivery nurse looks at you as the attending, and they look at you, and they insert a question telegraphically into your brain. And I'm going to let you know this, if ever a nurse with experience telepathically, inserts a question into your brain, your answer generally should be what? Yes. Thank you. So she's like, Dr. Crichlow, do you see what's going on? I'm like, yes, I do. She's like, Dr. Crichlow, would you like a vacuum? I'm like, nurse, can I get a vacuum on the table? Thank you, I appreciate that. So I'm like, giant intern. And you have to do the assessment like very, so how many vacuums have you done? None, Dr. Crichlow. Okay, you're gonna watch this one. So, got the vacuum on. I'm a Kiwi fan. I'm just gonna let it know. I have no financial disclosures. Get the Kiwi up. We're there. One of the things you do when you're doing and teaching at the same time is you pretend that you're telling the patient, but you're actually telling the resident. You guys know what I'm talking about. So like, man, we're gonna place the vacuum. It's gonna be gently holding the baby's head, and we really need you to push because you're actually gonna be the one that's doing this. We're gonna guide the baby out. Like, what? Good. She's like, get it out. She's like, no teaching. Move the baby. So I'm like, check for maternal tissue, and my intern checked for maternal tissue, and it's like, okay, contractions coming out. Good. So pump up the vacuum, and for those of you who have not done vacuum deliveries, the motion is sort of a down and up kind of thing. It's down and up, and you just sort of try to keep everything in line. And so I'm there, and it's like, okay, push. And I'm noticing that my elbow is like above my head, and I'm on my tiptoes, and I'm like, and the baby's still in. And I'm like, the bed is adjusted for my giant intern. So I'm like, nurse, drop the bed. And she's like, and then baby's out, intern delivers, baby's out screaming, mom's done screaming. And it was a hard birth. And honestly, that's when they need us. They don't need us when it's easy. And it was amazing. And the next day, my elbow swelled up like a grapefruit. And for 2 months, I couldn't straighten out my arm completely. I'm old, so that won't happen to you. But the lesson learned, adjust the bed to your height, not to the giant intern. So, beep, 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 pager goes off again, another July, not the same July. Oh, trigger warning. These stories are going to be about birth and death. Trigger warning, family medicine is about birth and death. And trigger warning, life is about what? Birth and death. Oh, you're in, okay, good. They're smart though. So, beep, beep, beep. July, actually all year long in the hospital, we have what's called a rapid response team. And rapid response team is an interdisciplinary team that arrives when a patient is in distress in order to hopefully not let it go to a code blue. And our residents are the ones who are the medical folks who respond. They're the physicians that respond. It's July, so I also respond. Westby, you know what I'm talking about. Yeah. So, get there, and I have an intern who does this thing when an attending shows up. They're like, Dr. Crichlow. It's like, what's going on? He's like, well, this guy, they said, and I'm like, no. Doctor, like, oh, we have 82-year-old patient. 82-year-old patient. The goal was if he could survive this, if he could tolerate the procedure, that they would continue interventions. But if he couldn't tolerate the procedure, he was going to go to comfort care. He's DNR and D9. And his vitals are currently unstable. He's agonally breathing. And what should I do next? I was like, okay. He's DNR and D9. He didn't tolerate the procedure. Let's get him back to his room. It's like, call his nurse, let him know we're coming back. You call his wife, tell her what's going on, tell her to get here. We go back to the room. The nurse is aware. She's gotten these. We have these sheets at our hospital for when people are in comfort care and dying, and they're beautiful. And she gets him in the bed. She takes out all the extraneous lines, and she even brushes his hair and gets a chair and puts it by the table. And he starts his agonal breathing. For those of you who aren't in medicine, agonal breathing, if you ever hear it, you know it. It's someone who's trying to die really hard. And he'd gotten to that place, and his wife wasn't there yet. And the nurse, she says she's going to be here in 5 minutes. And I was just like, I was looking at my very diaphoretic intern, and I was like, ooh, forgot to assess the intern. I was like, have you seen a death yet? I was like, no, I've never seen a death. Don't worry, we'll get through this. So I go over to the guy, and I was like, listen, names have been changed. I was like, Steven, and he's totally agonal breathing, totally out of it. I was like, Steven, you've got to hold on. Sophie's coming. She's coming. She said she's on her way. You got to hold on. And within a couple minutes, she rolls in. She just blows right past us. She sits in the chair, and she grabs his hand. She leans in, and she just says, I love you, 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 I love you. And she says that for I don't know how long. And he just dies. Now the thing is, when you're a doctor, that's not done. We had to declare the patient dead. In order to declare someone dead, you have to do an exam. My intern never done a declaration, never seen a declaration. So, teaching while doing. Got to check for pupillary reflex, shine a light, no response. Check for breathing, no response. Check for pulse, no response. Do a little trick where you put in your stethoscope and you put it on the patient's chest, but you're really just squeezing the heck out of their fingernail bed. You're checking for pain response. No response. Ma'am, he's dead. She's like, can I stay a while? I'm like, yes, you can. We're just gonna step out. And she just stayed there and she was hugging him. She gave him a little kiss. We left the room. And the nurse was crying, and I was crying, and the intern was crying. I was like, okay, what that just was is a good death in a hospital. Because I can't think of a better way to die than the person you love the most holding your hand and telling you that you are loved. So, I'm an academic family physician. We teach our learners how to guide our patients through the challenges and choices of life. Some of those are very mundane. Some of them are very profound. But all of them are awesome. It's family medicine, it's who we are, and it's what we do. And you should come join us.